The topic of my talk today is advances in laser technology. What I thought I'd do is try and sort of rewind the clock 20, 25 years and try and understand where laser technology in ophthalmology today came from, talk a little bit about where we are today, talk about some of the milestones in laser refractive surgery of what's made it what it is today, and then look at what's around the corner, so to speak. But really, from a laser perspective, it was the 80s that where it all kick-started. A guy called Steve Supracore in the US first noticed the potential of the excimer laser. It was originally developed by IBM from microchip etching, and he felt, well, if you can etch a microchip, why can't I etch a cornea? And he started to experiment and dabble in that area, and it sort of moved on to the point where by the mid-80s a gentleman called Theo Seiler in Germany had done the first, what we'd recognize today as a PRK on blind human eyes, and it all started really from there, from 1985. From a UK perspective, the first PRK was done by David Gartrey in 1989 when he was at St. Thomas's. The LASIK procedure as we know it today was pretty much invented by a gentleman called Ioannis Palikaris from Greece. And again, from a UK point of view, the first LASIK procedure was done by a Manchester surgeon, Emmanuel Rosen, in 1995. In 1987, the first excimer lasers were commercialized and sold to ophthalmologists, the real pioneers who wanted to get their teeth into this new technology. The company that I work for, Intralase, early on were making excimer lasers for another company called Meditech, but the head of the company, a guy called Christian Hohler, thought, well, if I'm making them for other companies, why don't I make them myself? So he formed his own company called Intralase and developed the 116 laser. That's a picture of the 116 just up here. It was a big beast of a machine. The patient lay down on this bed with this big bridge over the top and two big power units supporting that bridge either side of the laser. In those days, there were small optical zones, they were broad beam lasers, and there was no eye tracking whatever. The eye tracking was the surgeon saying to the patient, look up there, and the surgeon would hold the eye and guide the ablation. So it was quite skillful, shall we say, but decentrations, unsurprisingly, were not uncommon. In 1995, Intralase launched the first active eye tracker on an excimer laser. So it was quite a step change in the technology. It became less surgeon dependent on alignment, and consequently results improved. In '96, Intralase again made another step change and launched the 217 laser, which was the first flying spot laser treatment. It was a 50 Hz system. It had active eye tracking and a 50 Hz repetition rate, which actually is relatively slow for today's standards. Why did we move away from that? Well, broad area or multi-zone ablations at the time had a big beam coming down on the eye, and dependent on which laser you were using at the time, would use either an expanding iris to change the diameter of that beam, a bit like you get in an SLR camera, or an erodible mask that was on certain systems. They worked, but they were problematic. One of the problems with a broad beam system was you ended up with something called central islands. You had an intended, if I just use my pointer here, an intended ablation in the blue, but invariably you would end up with some central debris which had a visual impact on the patient's outcome. So Intralase played around with this flying spot notion. They started off with a 2mm spot rather than a 6 or a 7mm spot. And it became very quickly apparent that the material removal was much more dynamic, and it was a much more efficient process. So if you look from left to right here, what we're seeing is a schematic of a myopic correction being built. The 2mm spots are laid down, overlapping, and as it goes to the periphery, you are creating this myopic correction. So we're flattening, excuse me, the cornea. The net effect of that was that the actual ablation profile mirrored much more closely the calculated ablation profile. One thing that they didn't realize was with the flying spot systems, the homogeneity of the beam, so how even it was cutting, or ablating should I say, it didn't really matter or had much less of an effect on how even that laser beam was. If you had a grossly non-homogeneous beam, if that's the right terminology, the net effect was an undercorrection, which you could go back and retreat. It was quite easy to manage. With a broad beam laser, the older style machines, if you had a grossly unhomogeneous beam, you ended up with irregular astigmatism, all sorts of problems. It was quite difficult to manage. So this was a nice side effect of going to flying spot technology. In the late 90s, refractive surgery was booming. It was taking off. All manufacturers were selling lasers like hotcakes. It was happy days. It really was. The next big inception to come along, though, was the introduction of Wavefront, and that was introduced on the 217Z laser, which we launched in 2001. And this was taking a very different view to what had been done previously. Previously, surgeons had looked at what the refraction of the patient was in the spectacles, the contact lenses, dialed that into the laser manually, and done that treatment, and very successfully. But what a wavefront-driven treatment allowed them to do was correct those lower-order aberrations, but also correct some of these higher-order aberrations that people started talking about. So the aim of it was the ablation profile would be built up here. As the ablation profiles, the wavefront comes down, the point spread function becomes nice and sharp, the Strel ratio, beg your pardon, the RMS drops and the Strel ratio increases. In those days, everybody was doing LASIK and everybody was using a mechanical microkeratome. Mechanical microkeratomes at that time were pretty safe, and in good hands, generally you would get excellent outcomes. It was quick and it was relatively inexpensive to do. Intralase at the time was very, very slow compared to a microkeratome, but the pioneers in the day of refractive surgery saw the potential of this and really grasped the nettle and jumped on the bandwagon with Intralase, and it's been a very successful technology introduction, as you know. Another important introduction was something called the advanced Nomogram, which doesn't really sound that exciting, but from a surgeon's point of view, it was quite revolutionary in a way. A gentleman called Scott McRae at the University of Rochester had been using Xioptics for a while, and he'd noticed that a certain proportion of patients could see well in terms of visual acuity, but they were actually pretty unhappy. Other patients couldn't see that well, but they were very happy. And he couldn't understand this, and it made him start to look at why these cohort of patients were almost the opposite way around. And what he found was there was a specific relationship between certain higher order aberrations. Preoperatively, if you have more or less spherical aberration, if you treat that, it will have an impact on defocus. Preoperatively, if you have more or less trefoil, it will play a relationship with the degree of correction on astigmatism. And similarly for secondary astigmatism, primary astigmatism, spherical aberration, coma. So what he managed to do was build a nomogram, which from a surgeon's perspective was very, very simple to use. You did the scan, the wavefront scan preoperatively, you fed it into the advanced nomogram, and the nomogram would say, this patient has got X, Y, Z, pre-existing higher order aberrations, you should treat this. So what we had now was an eye tracker that would track actively, it would track passively, so when the eye is moving within a certain range, it will track and treat. When the eye goes out of a certain range, it will stop treating and alert the surgeon that it's out of range, so you bring the eye back in. But also with the introduction of ACE, it would track cyclotorsion. So if the eye torts under the laser, it will track and treat, and it also tracks in the Z-axis, so up and down as well. One thing that was introduced in 2008, developed by a surgeon in Bogota called Luis Ruiz, was a procedure called Intercore. What happens is a number of concentric rings are put into the stroma at predetermined distances, and a local subtle biomechanical change is affected, which makes the very central cornea hyperpolate, gives you good reading vision, but also maintains your distance vision. This is a real-time procedure, so the eye is docked. This is the laser going down on the eye. Very simple, very quick, painless. And that's it done. For the right cohort of patient, and that's generally emmetropes out to about plus 150s, you get very good distance vision and very good near vision. And it's not like bifocals, you get good intermediate vision as well. Recovery is very, very quick, painless, very, very good. Outside of that, you've got procedures called Supracore. This was launched at the ESCRS meeting in Paris in September. And this is, it's a bilateral excimer-based presbyopic correction. When you look at what other options are out there, a normal presbyopic eye will tend to have pretty good vision around this range. If you correct that with bifocals, you'll have pretty good distance vision, pretty good near vision, but your intermediate vision won't be very good. But with Supracore, we seem to have pretty much the full range covered. So in terms of laser-based, Intercore covers this sort of range here, so sort of from 0 up to about plus 150. Supracore falls outside of that with the excimer laser, and we feel that this cohort of patients here, 0 up to about -1, probably shouldn't be treated with any form of correction currently. What's coming down the line? What's coming in future? Well, femtoassisted cataract surgery is around the corner. There are a number of companies out there with machines that can do this. It's still in its infancy, but the technology looks absolutely astounding. The three companies at the top of the list there, LensX, Lensar and Optimedica, have dedicated machines that will only do cataract. The machine we launched at ESCRS does everything. It does flaps, it does Intercore, it does therapeutics, it does cross-linking. It will also do cataract as well. What is it? It's an ultra-precise OCT-directed femtosecond laser treatment for the creation of capsulotomies, lens fragmentation, surgical incisions, AKs, LRIs, and further down the line we're probably going to see femtosecond lasers becoming involved in glaucoma work. This is the graphical user interface of our machine. Just to show you how it works. The capsulotomy, you choose the size of the capsulotomy. You choose how deep or how anterior you want those vertical cuts to go, because this is going to start cutting inside the lens, come out, create the capsulotomy into the anterior chamber. You decide where you want it to be. So preoperatively you will have marked the cornea, you move the capsulotomy to be well centered around the apex of the cornea. You then decide what fragmentation profile you want for the cataract to be done. So this is inside the cataract. You can adjust the parameters here, and this particular one is a concentric circle pattern with some horizontal patterns as well. Do you want LRIs at the same time? Do you want incisions at the same time? It's all customizable. This is a video of a procedure being done. So they are, on the bottom right, they are choosing where they want the lens fragmentation to start and end. They're choosing the incision site and the incision size. And here's the procedure starting. This is the concentric rings inside the lens. It will then go on to do the capsulotomy, and you'll see some gas bubbles escape as the capsulotomy is created. So that's gas into the anterior chamber. Incision 1, incision 2. So this is the same patient. This was a fairly low-grade cataract, and this surgeon actually aspirates the whole lot out. He doesn't need any phaco. If you have a harder cataract, you would tend to use a different pattern and actually break it up and use a phaco machine to get the lens out. So there's the capsular rhexis coming out. just hydrodissecting. You'll see in a minute that nearly comes out on its own. It's that well broken. Goes in with his irrigation aspiration tip. All coming. Bit of cortical cleanup. I won't run it to the end. So that's pretty much bypassed the phaco machine completely for cataract. That was, and that seems to be the way this technology is going. So in summary, I certainly feel with these new developments in areas outside of traditional corneal refractive surgery, I think refractive lasers and femtosecond lasers in particular will play an increasingly important role in ophthalmology. What do they offer? They offer increased precision, reproducibility, and they will definitely improve the safety, efficacy, predictability and satisfaction rates for patients, requiring either elective or intraocular forms of vision correction. Thank you very much.